Welcome to study session 9, Major Disorders Occurring in Older Age. Learning outcomes for study session 9. When you have studied this session, you should be able to define depression, understand the different causes of dementia, explain the differences between dementia and delirium. Depression. A mood disorder is characterized by a depressed mood or cycles of depressed and elated mood, feelings of hopelessness and helplessness, and a decrease in interest, pleasure in usual activities. Depression is the most common psychiatric diagnosis. Major depressive disorder is a serious depression that involves impaired functioning and often suicidal thoughts. Dysthymia is a less severe depression that lasts at least 2 years in adults, 1 year in children. Risk factors, biochemical factors, family genetics. Parents with depression, child 10 to 13% risk of depression. Gender, higher rate for women. Age, often less than 40 when begins. Marital status, more frequently single or widowed. Season of year. Seasonal affective disorder, SAD, occurs when client experiences recurrent depression that occurs annually at the same time. It is thought to be a reaction to environmental factors such as climate, latitude, and decreased light. Psychological influences, low self-esteem, unresolved grief. Environmental factors, lack of social support and stressful life events. Reactive depression is in response to a specific life event, e.g., death of a spouse. Medical comorbidity. Clients with chronic or terminal illness, those who are postpartum or are currently abusing substances are especially prone to becoming depressed. Specific biological factors. Deficiency of serotonin, norepinephrine and acetylcholine. Effect of light in physiology related to SAD. Neurotransmitters melatonin and serotonin may be involved. Neurotransmitters subsensitive to impulses. Signs and symptoms. Feelings of hopelessness, worthlessness, and helplessness. Psychomotor retardation or agitation. Affect. Flat, blunted labile. Tearfulness, crying, melancholy. Altered thought process. Difficulty concentrating, focusing, and problem solving. May experience overgeneralization, dichotomous thinking, catastrophizing, personalization or pessimism, self-destructive behavior, decrease in personal hygiene. Loss of energy or restlessness. Sexual no responsiveness or disinterest. Physical symptoms of discomfort or pain. Risk of harm to self or others. Suicidal ideation or thoughts. Self-destructive acts. Violence. Over hostility, often connected with suicidal thoughts. Weight loss or gain, overeating or anorexia. Change in eating habits. Insomnia or increased sleep, withdrawal, social isolation, self-directed anger, loss of pleasure in daily activities, interests, or hobbies. History and physical examination to rule out medical causes for client complaints. Mental status examination, family history of depression, mood disorders, medical illness. Laboratory tests include sodium bicarbonate, calcium, magnesium, potassium, estrogen, progesterone levels, and thyroid stimulating hormone test. Dexamethasone suppression test of serum. Afternoon cortisol medications and meal can interfere with results. Nutritional assessment, including caffeine intake and vitamin and magnesium deficiencies. Psychiatric assessment and history. Sociocultural history, suicidal ideation or history of suicidal behavior or self-harm. Therapeutic nursing management. Safe environment. The client with severe depression and suicidal ideation may require hospitalization. Suicidal clients require one-to-one supervision until the acute threat or injury is resolved. Psychological treatment. 1. Cognitive behavioral therapy (CBT). Correcting or changing errors or distortion thinking. Altered thinking leads to altered behavior. 2. Individual psychotherapy. Long-term therapeutic approach or short-term solution-oriented may focus on in-depth exploration, specific stress situations, or problem of insurance coverage can affect the length of therapy that is received. 3. Behavioral therapy. Modifying behavior to assist in reducing depressive symptoms and increasing coping skills. 4. Social skills training. Techniques include operant conditioning, shaping, prompting and fading, positive reinforcement, extinction, generalization, discrimination, and cognitive processing schedules. May use role play to teach clients ways to improve interpersonal interactions, relationships, and independent living. 5. Self-monitoring. Clients become more aware of their symptoms and changes in symptoms, what affects them, and when and how to intervene or seek intervention to prevent further deterioration. Family and significant others are important in this process. Clients feel more in control if reasonable goals are established. 6. Behavioral contracts. Focus on specific client problem and needs to help the client resolve them, e.g., no suicide or no self-harm contract, isolation, social interaction contract, self-care contract. Social treatment. 1. Milieu therapy. Incorporates day-to-day living experiences in a therapeutic environment to affect perception and behavior. 2. Family therapy. Aimed at assisting the family to cope with the client's illness and supporting the client in therapeutic ways. 3. Group therapy. Typically, this therapy focuses on assisting clients with interpersonal communication, coping, and problem-solving skills. Some groups may involve more in-depth exploration of the nature of depression and strategies to relieve it. Access to insurance coverage affects the extent of therapy that the clients may receive. Psychopharmacologic and somatic treatments. Administer antidepressant medications, selective serotonin reuptake inhibitors (SSRIs), e.g. sertraline, Zoloft, citalopram, Celexa, fluoxetine, Prozac, paroxetine, Paxil, tricyclic TCA medications, e.g. amitriptyline hydrochloride, Elavil, monoamino oxidase inhibitors (MAOIs), e.g. tranylcypromine sulfate, PANIS. Continued assessment or monitoring of the client's mental health status is critical, particularly in the terms of agitation and suicidal ideation. Electroconclusive therapy. This therapy may be performed in inpatient or outpatient settings. The latter requires family or significant other support for aftercare in the home. Nursing intervention. Priority for care is always the client's safety. Use of behavioral contracts. Use this technique to meet outcomes relating to no self-harm or no suicidal attempts. Self-care and isolation. Assess regularly for suicidal ideation or plan. Observe clients for distorted negative thinking. Do not criticize the client, but instead provide concrete strategies to the client regarding a positive attitude and outlook on life. Pace this discussion. Acknowledge the painfulness of depression, but do not dwell on it. If client exhibits withdrawn behavior, gradually work with clients to increase activity one step at a time. Client needs to learn how to gradually increase social activity. Assist clients to learn and use problem solving and stress management skills. Avoid doing too much for the client, as this will only increase client's dependence and decrease self-esteem. It is a natural tendency to be overly cheerful to compensate for another's depression. This approach leads to false reassurance, which can be detrimental. It is true, however, that depression usually improves with time. The nurse's role in the physical care of the client experiencing major depressive disorder is to provide assessment and interventions related to appropriate nutrition, fluids, sleep, exercise, and hygiene, and to provide health education. Explore meaningful losses in the client's life. Aid the client in resolving issues related to grief process. Use a communication technique called reframing to help the client view a situation alternative ways. Encourage clients to practice skills learned in cognitive behavioral therapy, group and family therapies, social skills training, and symptoms management. Client and family education. Discuss with the client and family the possible environmental or situational causes, contributing factors and triggers for serious depression. Help the client and family to identify the internal and external indicators of major depressive disorder. Educate the client and family about the following issues: suicide prevention, stress management and problem solving, symptoms management, e.g. positive self-talk, involvement in activities and hobbies, medications, antidepressants, antipsychotics if hallucinating, family support, understanding, coping, social skills strengthening, self-care assistance when needed, and grief resolution. Complications: risk to self or others, anticholinergic and cardiovascular side effects of tricyclic antidepressants, sexual side effects of SSRI antidepressant, inability to care for self, nutrition, fluids, appropriate sleep, hygiene, exercise or rest, self-mutilation, long-term depression. Dementia: degenerative, progressive, neuropsychiatric disorder that results in cognitive impairment, emotional and behavioral changes, physical and functional decline, and ultimately death. Dementia is a chronic or persistent disorder of mental process caused by brain disease or injury. It is more progressive, gradual, and permanent. Involves a multiple cognitive deficits, primarily memory impairment. Involves at least one of the following: aphasia, deterioration of language function; apraxia, impaired ability to execute motor functions, e.g. combing of hair; agnosia, inability to name or recognize objects; disturbance in executive functioning, ability to think abstractly and to plan, initiate, sequence, monitor, and stop complex behavior. May also present with echolalia, echoing what is heard; palilalia, repeating words or sounds over and over; gait disturbance, uninhibited behavior, never have displayed these behaviors before; emotional outbursts are common; pattern of withdrawal, lethargic, apathetic, look dazed and listless. Clients may accuse others of stealing lost objects. First affects recent and immediate memory, eventually impairs the ability to recognize family members and oneself. Confabulation: clients make up answers to fill in memory gaps, often inappropriate words or fabricated ideas. Visual hallucinations are common. Initially grieve and then slowly lose sense of self. Some clients ignore internal cues such as hunger or thirst, neglect bathing and grooming, become incontinent. Clinical cause of dementia: early onset, 65 years and younger; rapid progression, late onset, over 65; highest prevalence over the age of 85. Stages: mild, moderate, severe. Mild: forgetfulness, difficulty finding words, frequently lost objects and experiences anxiety about these losses. Occupational and social settings are less enjoyable and the person may avoid them. Moderate: confusion is present along with memory loss. The person cannot complete complex tasks, but remains oriented to person and place. Still recognizes familiar people, some assistance with care. Executive functioning suffers especially with ADLS. Severe. Personality and emotional changes occur, may be delusional. Wander at night, forget the names of spouse and children and require assistance in ADLs. Causes of dementia. Decreased metabolic activity, genetic component, infection, Alzheimer's disease, Creutzfeldt-Jakob disease, CNS disorder, develops at 40 to 60 years. Causes by infectious particle that is resistant to boiling. Parkinson's disease, Huntington's disease, inherited gene, brain atrophy, demyelination and enlargement of the brain ventricles begins in late 30s. Treatments for dementia. Treat underlying cause, e.g. vascular dementia can be helped by diet, exercise, control of hypertension or diabetes. Assessment. Past and present health status compare to typical. Physical examination and review of systems, vital signs, neurologic status, nutritional status, bladder and bowel function, hygiene, skin integrity, rest and activity, sleep patterns, and fluid and electrolyte balance. Physical functions, self-care, sleep-wake disturbances, activity and exercise, nutrition, pain, etc. Demonstrate caring attitude, keep clients involved, relate to environment, validate clients' feelings of dignity, offer limited choices, reframing, offering alternate points of view to explain events. Physical and chemical restraint should be the last option. Psychopharmacology. Cognex and Aricept are acetylcholinesterase inhibitors, ACHEI, and have shown therapeutic effects, used to delay cognitive decline and slow the progress of dementia. They do not reverse damage already done. Must have liver function tests done with Cognex flu-like symptoms. Diarrhea, sleep disturbances are common. Tigretol and Depakote help stabilize mood and diminish aggressive outbursts. These doses are often half to 2/3 less lower than prescribed for seizures, therefore does not need to be in the therapeutic level for blood work. Benzodiazepines may cause delirium and can worsen already compromised cognitive abilities. Avoid medications with anticholinergic side effects. Delirium. Acute cognitive impairment caused by medical condition. Disturbance of consciousness, accompanied by change in cognition, disoriented but alert and oriented to person only. Typically have problems recalling on memory and time. Develops over a short period of time. Onset is rapid but different duration. Patient is easily distracted. Difficulty concentrating, illusions, hallucinations. Level of consciousness is impaired, slurred speech, anxious mood, usually reversible if underlying cause identified. Serious, should be treated as an emergency. Diagnostic criteria. Impairment in consciousness is a key diagnostic criteria. In children, can be related to medications or fever. Prevalence rates from 10 to 30% of patients. Higher for women than men, common in elderly. Post-surgical patients' causes of delirium is complex and usually multidimensional. Most commonly identified causes are infections, e.g. UTI, metabolic, fluid and electrolyte imbalances, e.g. low sodium. Normal is 135 to 145 mg per liter. Drug-related or withdrawal from drugs and alcohol, sedatives and benzodiazepines cause confusion or as a result of anesthesia. Variety of brain alterations like reduction in cerebral functioning, damage of enzyme systems, blood-brain barrier or cell membranes, reduced brain metabolism, imbalance of neurotransmitter and involvement of white matter. Interdisciplinary treatment and priorities. Elimination or correction of the underlying cause. Pay attention to life-threatening disorders. rule out life-threatening illness, stop all suspected medications, history of onset not reliable from client, interview family members, ask, is this how your patient typically acts? Pharmacologic assessment, substance abuse history, access for combinations of medications and OTC medications, mood or affect, frequently assess moods, moods change quickly, patient safety. Many have visual hallucinations, majority are very restless, hard to keep in bed, managing confusion and often frightened at night, protection from physical harm, low bed guardrails and careful supervision, encouraged to express fears and discomfort, adequate lighting, easy to read calendars and clocks, promote comfort and rest, reasonable noise level, adequate fluids and nutrition, always offer little sips of water, prevent aspiration, presence of family members can be helpful. Summary of study session 9. In study session 9, you have learnt that 1. Depression is mood disorder is characterized by depressed mood or cycles of depressed and elated mood, feelings of hopelessness and helplessness, and a decrease in interest pleasure in usual activities. Depression is the most common psychiatric diagnosis. 2. Dementia is a degenerative, progressive neuropsychiatric disorder that results in cognitive impairment, emotional and behavioral changes, physical and functional decline, and ultimately death. Clinical cause of dementia occur in stages namely mild, moderate, severe. Delirium is an acute cognitive impairment caused by medical condition, disturbance of consciousness accompanied by change in cognition, disoriented but alert and oriented to person only. 4. Causes of delirium is complex and usually multidimensional. Most commonly identified causes are infections, e.g. UTI, metabolic, fluid and electrolyte imbalances, e.g. low sodium. We have come to the end of study session 9.